Welcome to AETCM, the emergency medicine channel. Today we are discussing about organophosphate poisoning. We have two important insecticides, organophosphates and carbamates. Both are very commonly used insecticides. These insecticides can inhibit cholinesterase activity in our body. They can produce acute muscarinic features like increased salivation, increased lacrimation, increased urination, diarrhea, vomiting, increased bronchorrhea, bronchospasm, bradycardia and meiosis. So everything is increased lacrimation, salivation, urination, gastric secretion, vomiting, bronchorrhea, everything is increased. And they also can produce nicotinic features like muscle fasciculations and weakness. OP and carbamates, both are structurally different, but both will have similar type of features. Both inhibit cholinesterase activity at nerve endings. Many organophosphates have a characteristic garlic-like smell, which you might have read in your books. But when you have a patient with organophosphate poisoning, you can see a petroleum-like smell. Petrol-like smell is very classical, but books are given garlic-like smell. So clinically, it is petrol-like smell. We will see the agents in coming under OP. You have nerve agents that is mainly used in warfare by military. Most of the advanced military, we have this type of nerve agents. They are tabun, sarin, soman, cyclosarin and VXVR. We are not going to discuss about these agents. We are going to discuss about insecticides which is available in our country, dimethyl components and diethyl components. Dimethyl components are dichlorovas, phenethione, malthione, methamidamphos. Diethyl compounds are chlorpyrifos, diazinones, parathione or quinalphos. These are the common compounds which is available as OP agents in our country. So now we will see the mechanism of toxicity. Organophosphates irreversibly inactivate acetylcholinesterase in our nerve endings. This will lead to accumulation of acetylcholine at cholinergic synapses. Both organophosphates and carbamates inhibits acetylcholinesterase, preventing the breakdown of acetylcholine. That will lead to accumulation of acetylcholine at nerve ending. That leads cholinergic crisis. Carbamates are cleared spontaneously within 48 hours after exposure, but OP irreversibly bind to cholinesterase. So that is the difference between carbamates and OP. We will discuss about aging. It's a process. It extends the potential reactivation of organophosphate inhibited acetylcholinesterase, and it depends on the time. So when the time increases, time of bounding increases, that will produce complete irreversibility of this process. This is called as aging. Look at this nerve ending. You can see acetylcholinesterase can be increased. Their degradation will be prevented by OP and the levels will increase. That will lead to cholinergic crisis at nerves. So that is a mechanism. Now we can look at the toxicity. There are three stages of toxicity: acute cholinergic phase, intermediate phase and delayed polyneuropathy. We are going to concentrate on acute cholinergic phase. It starts in minutes, usually within 1 hour. It lasts for 48 to 72 hours and it can produce muscarinic, nicotinic and CNS effects. So we are going to talk about acute toxicity of organophosphate, that is acute cholinergic crisis. They have this acute phase has got muscarinic problem. All secretions are going to increase, sweating, salivation, lacrimation, increased urination, increased bronchial secretion, pulmonary edema. In that, increased bronchial secretion is very important because patient can have pulmonary edema, patient can have breathing difficulty, desaturation. All these things are complication of this increased secretion in the lungs. Then you can have meiosis, constricted people. But when you treat the patient with atropine, people start dilating. One of the indicator of reversal of the toxicity, but it should be never taken as the end point of treatment. Bradycardia is a classical findings in muscarinic toxicity, but many patients who can have tachycardia, that is because of nicotinic toxicity. So tachycardia is in around 20% of the OP poisoning cases. You can again get heart blocks, hypotension, bradycardia, all these things. So muscarinic toxicity mainly present with increased secretions, constricted people and bradycardia. You can see the mnemonic for muscarinic signs and symptoms. You can either remember it as sludge or dumbbells. Sludge is increased salivation, lacrimation, urinary incontinence, diarrhea, diaphoresis, GI upset and emesis. Dumbbells is diaphoresis, urination, meiosis, bradycardia, excess secretions, lacrimation and salivation. Now we'll see the nicotinic and CNS effects. Nicotinic effects are muscle twitching, fasciculation, weakness, respiratory paralysis, hypotension, tachycardia. Look at this nicotinic symptom, this hypertension and tachycardia. This is just opposite of previous finding. So 20% of the patients can have tachycardia, we have already explained. Twitching and fasciculation is the important feature of nicotinic effect. CNS effects like anxiety, restlessness, weakness, confusion, convulsions, coma can also be there in severe toxicity. Now look at the toxidrome of OP poisoning. You have muscarinic toxidrome, nicotinic toxidrome. Muscarinic toxidrome, you have differential diagnosis, like you can have same type of finding, carbamates, mushroom poisoning and OP poisoning, physiostigmine poisoning, pilocarpine poisoning, pyridostigmine poisoning. Nicotinic features can be there in black widow spider bite, carbamate poisoning, nicotine poisoning, OP poisoning. So these are the toxidromes seen in OP poisoning. Now we'll look at the intermediate syndrome. Intermediate syndrome begins after 48 hours. In nearly 20% of the case, you will get intermediate syndrome. It may be delayed up to 72 to 96 hours. Patients will have muscle weakness due to receptor dysfunction at neuromuscular junction. Muscles involved in the intermediate syndrome are ocular muscles. Patient can have ophthalmoplegia, neck muscles, difficulty to hold the neck in proper position. Forward fall is very common. Proximal muscle weakness can be there. Respiratory muscle paralysis can be there. It can lead to respiratory distress and intubation, ventilation. Many patients will have anxiety, sweating, cyanosis, and they may develop coma also. Now, another feature which is explained is delayed polyneuropathy. Many patients with OP poisoning, that too repeated exposure, chronic exposure can have myelin fiber demyelination, and that can produce delayed polyneuropathy. Most of the patients will have foot drop. That is a classical finding. Symmetrical, flaccid, distal muscle weakness lead to foot drop. So organophosphate induced delayed polyneuropathy can be there in severe poisoning, and many patients with chronic exposure can present with this finding. Now we can look at the diagnostic part of OP poisoning. Pungent garlic smell is explained in most of the books, literatures, but it is classically what you get in our practice is petroleum-like smell. Now we can send the patient samples for OP to a toxicological lab. So blood can be sent, gastric secretions can be sent, urine can be sent, and we can even send a serum cholinesterase level which will be reduced in the toxicological screening. So analytical toxicology has got a very important role when you have a poisoning with multiple material like OP or carbamate or like some other pesticides. Now we will look at the management of OP poisoning. So any patient who is having OP poisoning, for topical exposure, you have to clean the body, wash the body. All clothes should be removed from the body, and you can the body surface should be flushed thoroughly with normal water or soap water. All the caregivers should use personal protection equipments, because contamination from the patient secretion is very common during the treatment. Gastric lavage can be considered in oral poisoning if the patient present less than 1 hour. But some physicians recommend gastric lavage even after that, because of large, massive amount of poisoning. Maybe we can give gastric lavage even after 1 hour. But literature says it should be considered if the patient present, if it is less than 1 hour. But remember, most of our rural population will take massive amount of OP. So gastric lavage, if even after 1 hour, may be helpful. Do not induce emesis, so that is contraindicated. Activated charcoal can be given 100 gram initially, followed by 50 gram for hourly until the charcoal appears in the stool or patient improves. So activated charcoal can be given in multiple doses. Now the antidote for OP poisoning is atropine. Atropine infusion, it reverses the acetylcholine induced bronchospasm, bronchoria and bradycardia, hypotension. That bronchoria is very, very important, because that is an end point of treatment. So initial dose may be 1 milligram IV. If there is no adverse effects, you can increase the dose slowly. Drying of secretions are very, very important. Don't look at the tachycardia part, because anyway when you give atropine, massive dose of atropine, patient can have tachycardia. But our end point of treatment is drying of secretion, especially in the lungs. So auscultate the patient for drying of secretions. If you have crepitations, continue the atropine infusion. The vial contains atropine is 1 ml contains 1 mg, but the ampule contains 1 ml is equal to 0.6 mg. There is a difference between a vial and an ampule. So atropine should be given as infusion. You can give fixed split doses like 1 milligram every 1 hour. Like that also you can give, but infusions are always better, because atropine is a short acting drug. It relieves the bronchospasm and bronchoria. Monitor the patient's heart rate. Pupillary size can be monitored. Look for fasciculations, and most important is lung crepitations. Glycopyrrolate is an alternative for atropine, because whenever you are giving atropine, many patients can have atropine toxicity. Glycopyrrolate will not cross the blood-brain barrier, so it's an alternative. But remember, glycopyrrolate will not be useful in patients with CNS toxicity because of this OP poisoning. But whenever you have a patient who is having atropine-induced CNS toxicity, glycopyrrolate can be an alternative. Now, oximes are the type of drugs which can be used in OP poisoning. They reactivate phosphorylated acetylcholinesterase. It generates cholinesterase activity that has become inhibited by an organophosphate compound. So oximes can be used to reverse the cholinesterase activity. Pralidoxime is a drug which can be used as an oxime. Pralidoxime dose is 1 gram 8th hourly for first 24 to 48 hours. So it should be given in a acute OP poisoning. It is not useful against carbamate type poisoning. So it should be used in OP poisoning. Pralidoxime 1 gram in 100 ml normal saline over 30 minutes every 8th hourly for first 24 to 48 hours. Other treatment options are, if the patient is having seizures, treat with benzodiazepines or phenytoins. Respiratory failure should be treated with mechanical ventilation. Intermediate syndrome, if the patient muscarinic findings occur, they appear to treat, they appear because of the lower dose of atropine. You can treat with atropine that can be used in intermediate syndrome. Other treatments are like if the patient is having like chronic poisoning and or delayed polyneuropathy, the routine physiotherapy or limb physiotherapy may be helpful in this type of conditions. There no need to give again atropine or pralidoxin, that they are mainly useful in acute poisoning and intermediate syndrome. Chronic delayed polyneuropathy requires physiotherapy and limb exercises. So we have discussed about OP poisoning, acute poisoning treatment part. The toxicological part or analytical toxicology part will be dealt in a separate episode. Thank you.